Welcome, everyone. Thank you for joining us today for our April National Briefing webinar. My name is Amanda Holt, and I serve as the Director of Communications and Member Engagement here at the Patient-Centered Primary Care Collaborative. I know you are expecting a warm welcome from our President and CEO, Marcy Nielsen, as we usually do at the beginning of our webinars, but she will join us later in the presentation, and she'll moderate the Q&A at the end. I cannot possibly fill her very big shoes, but I do want to thank each and every one of you for joining us today. We're happy to share with you the latest on the Medicare Access and CHIP Reauthorization Act, or MACRA as it's commonly referred. Big news yesterday with the proposed rule released. So we have a lot to talk about in a very timely topic. We'll also spend some time in the presentation talking about the new Comprehensive Primary Care Plus model and how that model might intersect with MACRA. We have two fantastic speakers lined up who are experts and will be able to share their valuable insight with us. But before we get started, I definitely need to take a few minutes to go over a few announcements and housekeeping items. First, I'm proud to let you know that here at the PCPCC, we've been at the forefront of both MACRA and of CPC Plus. I would invite you to access our website for a whole host of resources, including the public statement we issued on April 11th, the same day that CPC Plus was announced. We also have information on CPC Plus on our Primary Care Innovations and PCMH online map. We've sent a letter to payers. We have CPC Plus talking points available to you on our website. And then just this past Tuesday, we were able to offer exclusive access to CMS officials for our executive members, where they could learn more about CPC Plus and ask questions directly to CMS. That is one of the many benefits that we offer our executive members, and I'll say another bit about that here in a minute. Next on the list is just a note about two of our most recent publications. You might be familiar with our Patient-Centered Medical Home Evidence Report that we release each year. We just released the latest version on February 2nd, so if you missed that, please do take a look on our website. And then just last month, we published in partnership with the National Business Group on Health an issue brief that makes a strong case for employer investment in primary care and the PCMH, another great publication. Two more quick announcements. Mark your calendars for our annual fall conference, November 9th through 11th in Washington, D.C. As we always do, we'll have sessions packed with valuable content and expert advice. But this year we'll also have a big celebration in honor of our 10th anniversary. So this will be an event you won't want to miss, again, November 9th through 11th. And then finally, a note about executive membership. As you can tell with all that's happening, primary care is a hot topic right now. If you'd like to join the movement, we would welcome you to join us as an executive member. Please feel free to access information on our website or reach out directly to me. And then just a couple of housekeeping items before we get started. We want to make these webinars as engaging and as informative as we can. So we allow time, about the last 15 or 20 minutes, to allow you to ask questions of the speakers. So to do that, please use the control panel on the right side of your screen and use the questions box where you will type directly in that box to submit your question. We will do our very, very best to get through all of the questions before the end of the webinar. And then finally, want to let everyone know that this webinar will be recorded, so we will have an archived version available for viewing on our website sometime within the next 24 hours. So without further ado, let's get started. I'm pleased and honored, actually, to introduce our two speakers. The first person to speak is Shari Erickson. Shari currently serves as Vice President of Governmental Affairs and Medical Practice at the American College of Physicians. That's the national organization that represents internal medicine physicians or internists. In this role, Shari advocates for ACP positions to all of the major federal agencies. She also directs and collaborates on the development of ACP policies and advocacy strategies in order to influence delivery system and payment reforms, such as accountable care organizations and patient-centered medical homes, as well as health insurance-related issues. The next speaker to present is Dr. Laura Sessums. Dr. Sessums serves as Director of the Division of Advanced Primary Care at the U.S. Center for Medicare and Medicaid Innovation, often referred to as CMMI. At CMMI, Dr. Sessums oversees the Comprehensive Primary Care Initiative and the brand new CPC Plus initiative. Previously, she worked in academic medicine as a clinician educator. Her professional activities have been in the areas of healthcare policy and advocacy, medical education, senior medical administrative leadership, and scholarship at the intersection of law and medicine. Her research has focused on primary care, particularly ethical and legal domains. She is a practicing general internist and a former lawyer. Tremendous thanks to both Shari and Laura for their time and expertise today. We are thrilled to have them. And now I'll turn it over to Shari, who will begin by discussing the details of MACRA. Shari, take it away.
Thank you so much, Amanda, and I'm really pleased to be presenting to the group today. I do hope that I can cover the highlights of MACRA in terms of what was incorporated in the law, and then obviously with the, oops, I'm going too fast, I apologize, with the most recent rule coming out yesterday, last night, yesterday evening, I guess. All sort of blending together. If you're like me, or many of you on the phone may have, like me, spent much of the evening and the early morning going through the rule of 900 plus pages or so. So I'll do my best to try to incorporate aspects of the rule, particularly related to medical home and primary care, to the extent I can throughout the presentation today. And then hopefully through the Q&A, I can try to help address some of those questions. And then obviously Laura is on the call as well. Her focus area, as was indicated, is the Comprehensive Primary Care Plus initiative, and she can obviously address some more specific questions related to that and Innovation Center activities. So what I want to start with is really just reminding us that MACRA is really part of a much broader, rapid push towards value and quality. Last year in January, HHS announced these new goals for value-based payments and alternative payment models in Medicare, looking to get 30 and then up to 50% of Medicare payments tied to quality or value through alternative payment models, and then 85 to 90% of Medicare fee-for-service payments tied to quality or value over the next few years. Following that announcement in May of last year, HHS formed the Healthcare Payment Learning and Action Network, which really incorporates both public and private stakeholders, including private payers, clinicians, and consumers, to work together towards substantially reforming the U.S. healthcare payment structure to incentivize quality health outcomes and value over volume. So that really gets at this idea that we're not just talking about MACRA, which is a more specific Part B or fee-for-service, physician fee-for-service payment law, is really one piece of a much broader movement. And then, just of note, in March of this year, just a couple months ago, or I guess about a month ago, HHS announced that it has already met the goal for 2016 of tying 30% of Medicare payments to alternative payment models. So things really are moving quite rapidly, and MACRA is a key component of that movement. So MACRA in a nutshell, And I would say that the Medicare Access and CHIP Reauthorization Act, and I just want to remind everybody, this is really a bipartisan piece of legislation, which is very rare these days. It was signed into law in April of last year and was supported by a number of different groups, including multiple physician specialty societies, consumer organizations, etc. And it was really a thoughtful piece of legislation that's complex, but has a number of components that we'll talk about that I think really do try to move our system towards a much more of a value-based payment system. So there are two components to MACRA, the merit-based incentive payment system and then alternative payment models. These are two different pathways, and they're outlined in more detail in the proposed rule that came out just yesterday. So as I mentioned, there are two pathways. And just to get into a little bit more detail, the merit-based incentive payment system, or MIPS, is focused on adjusting traditional fee-for-service payments upward or downward based on a new reporting program that brings together the existing reporting programs, PQRS, meaningful use, and value-based modifier, into one program. So getting at this idea of streamlining these separate programs that had very different types of requirements across them into one program with 4 measurement categories that are listed here on the left. Then the other pathway are the alternative payment models, which are supported by their own payment rules. So medical homes or accountable care organizations, etc., have their own rules, so to speak, and so those would continue, are expected to continue. But most of those alternative payment models still do have some fundamental underlying component that is fee-for-service. And so those fee-for-service payments, for those that are identified to be an alternative payment model under MACRA, will get an annual bonus of 5%. And I say fee-for-service payments, what I mean are Medicare fee-for-service payments, Part B payments, for those physicians who are getting enough payments from these alternative payment models. These alternative payment models also must involve upside or downside financial risk, which is incorporated in most of the ACOs or bundled payment arrangements that are available, or they could be a medical home if they're increasing quality without increasing costs, or if they're decreasing costs without having a negative impact on quality. One example of that potentially would be, as listed here, the Comprehensive Primary Care Initiative or the Comprehensive Primary Care Plus program that Laura will be speaking about a little bit later. Okay, so as I mentioned before, the MIPS really incorporates or brings together these existing reporting programs excuse me, into one program called MIPS. And I think that, people look at the legislation and think, oh, it's so complex, it's so difficult, I'm worried about it. But I think we really need to think about and remember that these programs all have different requirements, different measures. They, in spite of CMS's best approaches to try to align these, they were all established by different laws. And so there was really a fundamental problem and challenge in that CMS really couldn't legally even bring these programs together until the MACRA law was passed. And so now we have this opportunity to do so, and ideally do so in such a way that improves all of the programs and all of the components. So how will eligible providers, and actually I think that the term now, there's a slightly different term that they're using within the proposed rule, at least. I think they're saying eligible clinicians would be scored for MIPS. And there's, as I mentioned, 4 components: quality, resource use, which is actually being termed cost now in the new proposed rule, clinical practice improvement activities, and meaningful use of certified EHR technology. And there's also a different term now for meaningful use, at least as it applies to Medicare Part B, and that is advancing care information. It's a fundamental change in the meaningful use program, which I'll try to talk about a little bit, or we could get at it in some of the Q&A to the extent that we can have time to do so. And what's really important actually on here, the first line and towards the bottom, the 2019 percentages are what's applicable and what is actually addressed in the current proposed rule. Quality is expected to account for 50% and resource use 10%. in the 2017 reporting period, which would then apply to the 2019 payment period under MIPS. And so those percentages of 15 for quality, or 50, excuse me, for quality, 10% for resource use, 15% for clinical practice improvement activities, and 25% for what is now called advancing care information will add up to a composite score of 0 to 100 for MIPS. What I want to mention is more specifically, particularly for this audience and for those interested and involved with the Patient-Centered Primary Care Collaborative, is I know we all care very deeply about ensuring the ongoing testing, understanding, and spread, ideally, of the patient-centered medical home. And I think it's particularly relevant in the new system under the clinical practice improvement activities category of MIPS. This is another acronym, but at the same time, I think it's ideally a good one. And when these bullets were put together, really based on what's in the law, but I think that the proposed rule really aims at meeting the intent of these bullets. So the clinical practice improvement activities have been set out to be established in collaboration with professionals, clinician societies. The Secretary also must consider if they are attainable for small practices and those in rural and underserved areas. And those aspects are addressed specifically in terms of proposals in the proposed rule. Certified, in quotes here, as it needs to be defined, and there's a proposed definition for this in the proposed rule. Certified PCMH and PCMH specialty practices are intended and are expected to receive the highest potential score for clinical practice improvement activities. There are a number of key questions I have listed here, again, that were outlined in advance of this rule coming out yesterday. And I think that a lot of these are starting to be answered. With, this, again, what came out yesterday, just for clarity's sake, was a proposed rule in the way CMS, at least in the calls and discussions that I was involved with yesterday, really has put that proposed rule out there and indicated that it really is a starting point for discussions, for feedback, for input by all of the stakeholders on this webinar and that are involved with healthcare delivery to give CMS and to have with CMS in terms of helping them to get to a place that really meets the needs of ideally and most importantly the patients and the beneficiaries of Medicare, but also for those other stakeholders involved in the system. So the proposed rule does discuss how they are intending to, or how they're proposing to report and track some of these clinical practice improvement activities. It does also discuss some of the definitions they're proposing for medical home and medical home specialty practices. It also discusses some of the things they're thinking about or their thought process around programs that are led by others. And Laura will get into talking about CPC, the Comprehensive Primary Care Initiative, and the Comprehensive Primary Care Plus program, which and the Primary Care Plus program was specifically identified in the proposed rule as being one that would qualify as an advanced alternative payment model for that pathway within MACRA. I'm just moving to the next slide. I have a little delay. Let's see if I can get there. Trying to behave and not hit the advance button too many times because I know that when I do that it will go too fast. Okay, so MIPS can adjust payments as I indicated. This is an outline of how much it can adjust payments over the next several years. 2019, based on 2017 reporting as proposed in the rule that was released yesterday, would be upwards of 4 or downwards of -4%. Again, that is using the composite score to determine where one would fall, so to speak, on a spectrum with a threshold. And if you're above the threshold, you can go above. You can get a positive adjustment. If you fall below, then you get a negative adjustment. And that goes up over the next several years after that to plus or minus 9%. And again, this is an adjustment on the base Medicare Part B payment. Those that score in the top 25% are also eligible for an additional annual performance adjustment of up to 10% from the years of 2019 to 2024. This is not incorporated in the budget neutral adjustments that are outlined here. So alternative payment models, and the initial definitions from the law are outlined here. An innovation center model, like Comprehensive Primary Care Plus, Medicare Shared Savings Program, the other demonstrations that are part of federal law, and this definition is incorporated into the proposed rule that came out yesterday. And they also note that there will be other alternative payment models, and in fact, the term used in the proposed rule now to get at this pathway is actually advanced alternative payment models versus other alternative payment models that may not be qualifying under this definition. Again, MACRA doesn't define or doesn't change how any of these particular APMs reward value. And then there's the annual 5% bonus on the fee-for-service components. Medical homes do get some special treatment under the alternative payment model pathway with some caveats that I mentioned earlier related to their ability to improve quality and reduce costs. And again, over time, and this is again addressed in the proposed rule, other options will become available through the Physician-Focused Technical Advisory Committee, as well as and their recommendations to the Secretary, as well as later when other payer payments and programs are able to be considered for alternative payment model options. And that will start a couple of years into the implementation of this law. And I think that Laura may get at this, and I won't go into it a lot. This gets somewhat in the weeds. But the way I'm reading it, the way I've read it at least in terms of the law, there are two sort of basic screens, so to speak, for an alternative payment model, or now what is being termed an advanced alternative payment model. So there's an eligible APM, which now I think is the advanced APM. And these, again, are the most advanced ones that meet the criteria according to the law. And they have these three different components that need to be incorporated: basing payment on quality measures comparable to those in MIPS, requiring the use of certified EHR technology, and either bearing more than nominal financial risk or, again, being a medical home model expanded under the Innovation Center Authority. So that's the model. That's the actual program, so to speak, that goes through this first screen. And then beyond that, then you get into the actual individuals, the clinicians that are participating in these models. And those are physicians or other clinicians that have a certain percentage of their patients or payments that are coming through this eligible alternative payment model. So if you're in what is determined to be an eligible APM, you may not have enough patients or payments to be, so to speak, a qualifying participant on the APM pathway. But with that said, for those patients that you are getting Medicare payment for, you would certainly do quite well. I think it would be expected to do quite well under the MIPS side of things, so to speak, because you would be getting quite a bit of credit for your work on the clinical practice improvement activities and the quality reporting you're already doing. I mentioned before this technical advisory committee. Within the proposed rule that just came out yesterday, there are more specifics around this advisory committee that are laid out. It has been appointed by the GAO, and they've had an introductory meeting, and then another meeting will be coming up soon of this technical advisory committee. They will be reviewing models that are put forward to them and submitting recommendations to the Secretary, who can then consider testing that model as one that could become an advanced APM over time. Waiting a moment for the slides to advance. I apologize. Oh, I think that I might have gone too far. Let me just go back up one and see if I have one more slide to cover to wrap it up before I move on. I seem to be messing things up. So Amanda, I don't know. There we go. So yeah, one more down. And now that I know what that slide is, and I remember, now I can talk about it, even as we wait to get to it. So there is a, excuse me, an implementation timeline laid out here for this implementation of MACRA. One thing I want to say is that what happened in the proposed rule, and there are definitely terminology changes in the proposed rule that I think are quite helpful. They're calling the new program the Quality Payment Program, which includes these two paths of MIPS and APMs. And they've changed the terminology related to meaningful use. They're calling resource use cost. So there are a few different terminology changes that I think were quite helpful. And based on what I understand, the CMS held a number of focus groups over the past several months to help inform them in terms of what they were, the terminology, as well as a number of other aspects of the implementation in advance of this proposed rule. And I think that's been quite helpful, at least. I definitely have noticed in the rule, the proposed rule, some improvements in the way things are outlined, and definitely a responsiveness, so to speak, to date of the feedback they've gotten. I think that there's a lot of room for us to get more feedback, and I encourage everyone on this webinar to do so. So I just want to mention, we just got the proposed rule under the spring 2016 piece, and we are expecting the final measure development plan that's required by the law. We didn't speak a lot about that, but it is another component of the law that that should be coming out, I believe, next week. And then over the summer, we'll be getting the regular physician fee schedule proposed rule that usually comes out around July 4th. That rule traditionally has held a lot of components and proposals in it related to the existing reporting programs like PQRS and value-based modifier and meaningful use sometimes. And I think we can probably expect there will be components related to MIPS and APMs perhaps that could be in that rule that maybe weren't incorporated as much in this current proposed rule that we have. And then in the fall, the physician fee schedule rule will be finalized, as it typically is, around Halloween timeframe. The MACRA final rule for the 2017 performance period is also required to be finalized, I believe, by around the beginning of November. And then we'll also get the end of quality measures that will be used in MIPS by November 1st. So a lot of activity this year in the implementation of this law. We're in the midst of that now, and I think we can look forward to more of that this year and then in the coming years as we look to refine the program over time. Now I'll move it on and let Laura take over and talk more specifically about the Comprehensive Primary Care Plus initiative and any other Innovation Center components that she'd like to address.
Thank you so much, Shari. I'm going to just back up a little bit to the discussion about the transition for value, which is the way Shari began her part of this talk, to just level set as I move into a discussion of alternative payment models and advanced alternative payment models. But I think it's helpful to understand the context here. As you will see in the diagrams, the two circular stacked circles on the right, the delivery system reform goals for health and human services are to move payments under Medicare Part B to value. This diagram shows in yellow is all Medicare fee-for-service. The lighter green, 85% in 2016, is fee-for-service payments linked to quality and value. And then the darker green are those payments tied to quality and value versus via an alternate payment model. And the hashed circle, the very smallest of the stacked circles, are Medicare payments to those in the most highly advanced alternative payment models. And you can see the Secretary's goals are to move the darker green from 30 to 50. What we're going to talk about here for the next couple minutes is really the even smaller circle, the hashed circle there. The way that MACRA provides financial rewards under the proposed rule, and it's important to remember the rule at this point is proposed, is a spectrum of proposed increasing financial rewards. So for those who are not in an alternate payment model, as Shari pointed out, there's the MIPS score with the potential for both positive and negative adjustments. For those in an alternate payment model, there's MIPS score adjustments plus the alternate payment model specific rewards. For those who have significant participation in an advanced alternative payment model, there's the alternative payment model specific rewards and a 5% lump sum bonus. So I think important to note here that the law doesn't change how any particular APM rewards value. Instead, what it's doing is creating incentives, extra incentives for participation in advanced APMs. And for the years 2019 through 2024, a clinician who meets the law's standards for advanced APM participation is excluded from the MIPS adjustments and receives a 5% Medicare Part B incentive payment. But to qualify for the incentive payments, clinicians would have to receive enough of their payments or see enough of their patients through advanced APMs, and that's what we mean by significant participation. So as you can see here, under the proposed rule, CPC Plus is listed as a proposed advanced alternative payment model under the special rules for medical homes. And you can also see all the boxes there are checked yes. So let me explain this a little more. Under the law, advanced alternative payment models, those in which clinicians accept risk for providing coordinated high-quality care. And as proposed, to be an advanced APM, models must be a CMS Innovation Center model or a statutorily required demonstration. And generally, they must do a number of things. They have to meet certain financial risk requirements. They have to base payments on quality measures comparable to those used in the MIPS performance category, MIPS quality performance category. So to meet this requirement, the proposed rule is proposing that an advanced APM must base payment on quality measures that are evidence-based, reliable, and valid. And in addition, at least one such measure has to be an outcome measure if an outcome measure appropriate to the advanced APM is available on the MIPS measure list. And then it must require participants to use certified EHR technology. Under the proposed rule, an advanced APM must require that at least 50% of the clinicians use certified EHR technology to document and communicate clinical care information in the first performance year, and this requirement increases to 75% in the second performance year. Oh, that was too fast. So there's some special rules for medical home models. And under the statute, medical home models that have been expanded under the Innovation Center Authority qualify as advanced APMs regardless of whether they meet the financial risk criteria. While medical home models have not yet been expanded, the proposed rule lays out criteria for medical home models to ensure that primary care physicians and other clinicians have the opportunity to participate in advanced APMs. The rule proposes a definition of medical home models which focus on primary care and give accountability for empaneled patients across the continuum of care. Because medical homes tend to have both less experience with financial risk than larger organizations and also limited capability to sustain financial losses, the rule proposes a unique advanced APM financial risk standard consistent with the statute to accommodate medical homes that are part of organizations with 50 or fewer clinicians. And that language here on the slide is just bolded so that you can see that there. And this is directly from the rule itself. Also, you will see on the bottom of this slide and the former is the URL for the rule. And at the very beginning, it identifies ways to comment, and all comments must be received by 5 p.m. June 27th. And we encourage you to provide all good comments on the rule. It would be helpful.
All
So
right.
with that, I'll stop.
Great. Thank you, Laura. This is Amanda again. We were hoping that Marcy would be able to join to help moderate Q&A, but unfortunately she is at the podium giving a keynote address at the moment that ran late. So I will go ahead and start asking several of the questions that we've had come in from the audience. I want to remind the audience that in order to ask a question, you'll simply type in your question to the questions box that you'll see on the right-hand side of your screen. We've had several questions, and Shari and Laura, feel free to answer both of you, or one of you can choose for each question. But one of the common questions I'm seeing is it deals with FQHCs. People are hearing that FQHCs are not eligible. Can you speak to that?
I have to be honest and say I haven't looked at that component of the rule, but I have it up and I can do a quick search and see what I can find. This is Shari, by the way. I don't know if Laura wants to address it and see if she has some knowledge about it.
No, I think I don't. So sorry, I can't help on that one.
That's okay, and we are happy to get back to folks with answers once all of us have had more time to read through with a fine-tooth comb the proposed rule and all that it entails. Other questions that we've had come in: is a certified patient-centered medical home the same as NCQA recognized?
Sorry. So is a certified medical home the same as NCQA recognized? That's the question?
Yes, that is the question. And we have several other similar questions, but they use slightly different words.
Okay. So I think I can answer what has been proposed in the proposed rule, and Laura may wish to add to that as well. In the proposed rule, they have defined a patient-centered medical home to be recognized as recognized by a nationally recognized accredited patient-centered medical homes are recognized if they are accredited by, there are 4 different entities listed. And one is the Accreditation Association for Ambulatory Health Care. The second is NCQA, PCMH recognition. The third is the Joint Commission designation, and the fourth is the URAC recognition, or I forget. And then there are a couple of other, so that's the core group of organizations they've identified as or proposed to be those that would count for certification, for the CMS defined certification of a medical home or patient-centered medical home. They say that the criteria for being a nationally recognized accredited patient-centered medical home, that it must be national in scope and have evidence of being used by a large number of medical organizations. They also then have 2 other, and I'm going to say options, I'm not sure that's the right term. They define, and this is in capital letters, what I'm saying is Medicaid medical home model, again in all caps. And then they also then use the term, again in all caps, medical home model. Those 2 models are then defined a little bit later in the rule and have some other specificity around them. That's what I know at the moment, and I think that Laura may be able to add a little bit to that, obviously, given the relevance of the Comprehensive Primary Care Plus program to MACRA and to medical home.
Actually, I think you covered it really nicely, Shari.
It means I actually understood what I read last night.
Great, thank you both. And it sounds like maybe you may have answered one other question, and we have someone asking, what about a patient-centered medical home practice that is recognized through a state-specific criteria, such as in Oregon? I'm wondering if that would qualify.
I think we need to look at that. I have to be honest, I don't know for sure all those answers. That's one of the things I want to dive in, certainly, and probably many, or if not most, or all of us on this webinar want to dive in and understand better how there are a number of state programs out there. And I think we need to, that's where we need to dive in and understand the components of the sort of capitalized Medicaid medical home model or a medical home model terms are defined, and to see if we think that those programs would fit within those definitions. And the other thing I want to emphasize on that is this is, again, proposed. So if you have concerns that you believe should be counted as an advanced alternative payment model, or counted for full, and/or I should say counted for full credit under the clinical practice improvement activities within MIPS as a medical home, then I think you should comment on that, and at the very least seek clarity from the agency, but perhaps probably more likely tell them that you think it should be counted, so to speak, in terms of those definitions and why. And I think that will be helpful feedback to get to the administration and to the agency as you look at the rule.
Thank you, Shari. That's really helpful. Another question we had come in is whether you anticipate that private insurances will start using a MIPS-like model.
I don't think I can answer that on their behalf, but I will say a couple of things. And this is referenced in the proposed rule, and also was referenced in the draft measurement plan that CMS put out in March, which they will be finalizing by next week. There's a core measure coalition that the AHIP, the American Health Insurance Plans, sort of led and brought together a collaboration of a number of private payers, as well as clinician organizations, consumer groups, employers, and CMS, that met over a number of months, I think it was, to identify a core set of measures around certain areas, including medical home and ACOs. So primary care is, I think primary care was the focus of that category of measures, and I think it was about 6 or 7 other categories of measures that they identified a core set that essentially all of the payers around the table, as well as CMS, with the input from the physician organizations and consumers and others, agreed to. Now, nobody signed a hard and fast contract, but essentially agreed that those would be the set that they would really start to look to use. And again, these are quality measures. So, I think there's an anticipation, and CMS references this core quality measure set and identifies those measures within the proposed rule under the list of measures that I forget what table that is. I want to say A, but I could be wrong. And they identify which ones are part of that, that were identified through that collaborative work. And then I think there was sort of an expectation and a hope that the payers around the table would then start to look at their contracts with the practices around the country and start to move towards using those measures in those contracts with the entities, that they work with the physician groups that they work with. So at least on the measures front, I think we're looking at more alignment over time here, and will the payers move into a true MIPS-related type of, or MIPS, something that looks like MIPS? I don't know. I mean, a lot of them are doing have been doing a lot of medical home-related work for a number of years, even in advance of CMS getting more into this space. So it's possible, but obviously I can't speak for them.
Thank you, Shari. And the next question I think might be one targeted more for Laura, but Shari, feel free to chime in as well. This person is asking, what type of technical assistance will CMS provide to CPC Plus participants to help them with transformation activities?
Oh, sure. Yeah, just as we did in the Comprehensive Primary Care Initiative that's in its final 4 years now, we have a robust learning system that has both national and regional components with face-to-face sessions nationally and regionally, as well as practice coaches and a platform for peer-to-peer sharing that we call CPC Connect. So lots of resources and help to help practices move through the care delivery requirements of the model over the 5 years.
Great, thank you, Laura. And back to the MACRA proposed rule here. I'll just ask you to repeat. We're having several folks ask when the rule will be made available and when the deadline is. I know you mentioned that earlier in the webinar, but if you could go ahead and repeat that, I think that would be helpful.
This is Laura. The rule, I don't know if I can probably switch the slide maybe back to the prior one. It's at the bottom of the slide is the URL there, if everyone can see that. And it is open for comment now. And so feel free to go ahead and read and provide comments. Comments will, the opportunity to comment ends at 5 p.m. on June 27th.
Thank you, Laura. Next question is really focused on larger practices, and this person is asking, if you have more than 50 providers, can you still participate in the advanced PCMH model?
I think what that question is getting at is, can you participate in CPC Plus if you have more than 50 clinicians? And the answer to that question is yes. What the proposed rule is proposing is that the participants of an organization with 50 or more clinicians would not be entitled to the 5% advanced APM bonus. They would be entitled to the other rewards under the model.
Great, thank you, Laura. We have several questions, and I'm really trying to sift through them so that we answer as many as we can without repeating too much. Let's go to CMS usually bases adjustments off of a 2-year retrospective data. Does that to the 2018 adjustments will be based on 2016 data? So it sounds like they're asking whether the 2018 adjustments will be based on this year's data. Is that correct?
So this is Shari, and so the 2018 adjustments are based on 2016 data, which are based on the existing programs, PQRS, Meaningful Use, Value-Based Modifier. Those programs are still in effect this year for 2016 in terms of reporting related to 2018 adjustments. Interestingly, one slide I did not include was that if you add up, so if you're a clinician in your worst case scenario, you're really not doing any reporting or anything at all, say in 2016. The negative adjustments you could receive actually add up to probably close to 9% when you put PQRS plus value-based modifier plus meaningful use. But then when we move into 2017 and we move into the MIPS program, which is when the reporting period is for 2019 MIPS, so And then say if you continue to do none of that, which I think is not ideal, then the highest sort of negative adjustment you could get would be 4%. So even if the rule, seems to be quite complex and there are concerns about that, obviously in addition to the streamlining of these programs, the incentives are adjusted to be much more reasonable, certainly in the earlier years, and then over time the amount at risk, so to speak, in terms of potential negative adjustments goes up, but also the amount you can get goes up. And there's no real opportunity for that right now within the existing programs, so I just want to highlight that as well. And the other component of that question, I think, was the 2-year look back. And yes, CMS has proposed that 2017, the full year, starting January 1 of 2017 through the end of the year, would be the reporting period for MIPS for the purposes of a payment adjustment in 2019. I need to look more specifically at the details, but I certainly recall that the clinical practice improvement activities component or category within MIPS, there's like a list of 90 or so options that you could that could be attested to in a variety of different ways. There's a lot of flexibility there, which I think is positive. Any of those one activities, so to speak, if you're doing that and you're going to report on that for your for the clinical practice improvement activities category, or if it's medical home, there's a 90-day period. So you don't have to start off January 1 saying, oh, I got to start clinical practice improvement activity right away, or else I'm not going to get any credit for that for the year. You do have some time because it's a 90-day performance period, so to speak, for the clinical practice improvement activities component of at least proposed. Again, this is all proposed of MIPS. So I think that's a positive thing. So it does give folks an opportunity to sort of get their feet wet and figure out what they want to do. There may be things we're already doing that would count right away in January, but if not, then you have some time to get something else started. I cannot recall the performance period within the year of 2017 for the other pieces, if it's all year or if they're 90-day pieces. I need to look at that. But I just wanted to mention that I do remember that is the case for the clinical practice improvement activities, at least as proposed.
Thank you, Shari. That is all so very helpful. We have time for just a couple more questions. One question here is about attribution. And the person is asking, given that fee-for-service patients can choose to see any Medicare provider, in MIPS, how will patient care be attributed to a particular physician or medical group?
Great question. So I don't know if I know the full answer. I need to look at this in more detail, quite honestly. And again, this is all proposed. I do have a note here in terms of the definition for primary care for attribution purposes is proposed to be modified to better align it with the shared savings program and with those that provide chronic care management and transitional care management services. I don't know exactly what that means. I think particularly with the resource use component of MIPS, there's a lot that still needs to be sorted out and over the next year or so. At least initially they proposed just to use claims data for that piece. But so I don't really know if I have an answer, but I know they've proposed within here some potential modifications, particularly related to primary care attribution, that could be good if it certainly does align with other activities and programs that primary care clinicians are engaged in. I don't know if, Laura, you have any other thoughts on this. I'm still digging in on that piece.
And
Sorry, I couldn't get off of mute. Sorry about that.
There you are.
It locked me out and I couldn't get off. No, I think it's complicated as the questioner is realizing, and again, I have not focused myself on this aspect of the rule yet. So I think more to come.
Great, thank you both. Let's end with one last question that's really less about the nitty-gritty details and the technical aspects of MACRA and CPC Plus and more about the bigger picture. And so this question is, to what degree is the pending fundamental shift in payment models addressed in medical, nursing, and other healthcare professional training curricula?
I'm not an expert in that area, so I'm not sure how much I can say. I do think that there is probably a need to help physicians and other clinicians, nursing, and et cetera, to move towards understanding. I think the key is team-based care. I think that all of this movement towards true value-based payment really gets at the need for a true team within a practice as well as across practices who sort of share accountability for patients. And so, I would imagine, and again, this isn't my main area, not at all my area of expertise, but there is a probably significant need for growing programs that can help clinicians coming up through the system to be able to get out the ground running, so to speak, for providing true team-based care.
Yeah, this is really not a rule question so much as it's been very difficult, and heard this just even this past weekend at a conference, that it's very difficult for training programs to revamp their training in advance of new payment strategies and care delivery strategies occurring. But I think, I expect, this is my own personal opinion, that over time the changes in the law and regulation will drive those changes at the training level, so that those who finish programs will be prepared for practice.
And Laura, that is very much our hope as well here at the PCPCC, and something we will be focused on helping support as well. So with that, we are at the top of the hour. I want to thank Shari and Laura again for their time and their expertise. What a great and very insightful presentation today. Thank you both. I also want to thank the audience for participating, and then one final reminder that you can access an archived version of the webinar on our website within the next 24 hours. You would go to pcpcc.org/webinars, and that's where you can view the webinar again. Thank you again, and have a great rest of your day.